Picture this. You're 82 years old. You feel good. You're sleeping reasonably well. You have energy for the things you care about, and nothing about your day-to-day life suggests anything is wrong. You go in for a routine annual physical. Nothing dramatic. Your doctor looks at your chart and says, "Let's run a few tests just to be thorough." Weeks later, you're sitting in a specialist's office. Not because you felt sick, but because one of those routine tests found something. And now you're facing decisions you never expected to make. About a body that, as far as you could tell, was doing just fine. This scenario is real. It happens. It does not happen to everyone, and it is not the inevitable outcome of routine care, but it happens often enough that geriatricians, primary care physicians, and health policy researchers have spent the last 2 decades studying it seriously. The formal name for the underlying problem is overdiagnosis and overtreatment, and it's one of the more important, least publicly discussed issues in modern medicine. My name is Dr. Paul, and this channel exists to help people over 60 make sense of what the research says about their health, in plain language, without either panicking you or oversimplifying things to the point of being misleading. What follows is not a list of tests to refuse. It's an explanation of how the risk and benefit math shifts with age, which specific screening decisions deserve a slower, more deliberate conversation with your doctor, and most importantly, the exact questions that turn a rushed 15-minute appointment into a real, informed discussion. I want to be upfront about something. This video simplifies a genuinely complicated area of medicine. Real decisions depend on your specific health history, your family history, your current symptoms, your other medical conditions, and your personal values about risk. Nothing here should replace a conversation with your own physician, who knows your actual medical record. Think of this as preparation for that conversation, not a substitute for it. Screening medicine is built on a simple premise. Find a problem early, before it causes symptoms, and treat it while it's still manageable. In a 50-year-old, this logic tends to hold up well. A cancer caught early in someone with several healthy decades ahead of them can genuinely be cured, and the person can go on to live a long, full life because of that early catch. The investment of time, discomfort, and risk pays off on average across large populations. After age 70 or so, 3 things change, and understanding them is the foundation for everything else in this video. First, lead time and biology. Many conditions that show up on a screening test, small thyroid nodules, low-grade prostate cancers, minor coronary artery narrowing, mild bone density loss, grow or progress so slowly that a person is statistically more likely to die with the condition than from it. This is especially true the older a person is when the condition is found, because there's simply less remaining lifespan for a slow-moving problem to become dangerous. Pathologists and epidemiologists sometimes describe these as findings that would never have surfaced clinically if no one had gone looking for them. Second, physiological reserve. The human body's capacity to tolerate stress, surgery, anesthesia, invasive procedures, aggressive medication regimens, generally declines with age, though this varies enormously from person to person. A 55-year-old and a 78-year-old undergoing the identical procedure are not undergoing the identical risk. Recovery time, complication rates, and the chance of losing functional independence afterward all tend to rise with age, particularly in people who are frail or who have multiple existing health conditions. Third, the cascade effect. This is arguably the most underappreciated part of the whole picture. Medical systems are built to act on abnormal findings, not to sit with ambiguity. A borderline result on one test often triggers a follow-up scan. The scan may recommend a biopsy. The biopsy may lead to a procedure. The procedure carries its own risk of complications. Each step is individually reasonable. No one along the way is doing anything wrong. But the cumulative chain can take someone from feeling completely well to navigating a genuinely difficult medical situation, all set in motion by a test that, statistically, didn't need to happen in the first place. None of this means screening is bad, or that doctors are careless, or that you should refuse tests reflexively. It means that the calculation of "is this test worth doing" is not fixed. It shifts with age, health status, and individual risk. And it deserves to be revisited rather than applied automatically. Keep this framework in mind as we go through 5 specific areas where the research suggests that conversation is especially important. 1. Routine colonoscopy. After age 75, colorectal cancer screening has one of the strongest evidence bases in all of preventive medicine, and it has saved a substantial number of lives since it became widespread. That's worth saying clearly because nothing below is an argument against screening in general. The US Preventive Services Task Force, independent panel that sets the evidence-based guidelines most American physicians rely on, recommends against routine colorectal cancer screening for adults 76 to 85 who are at average risk, and recommends individualized decision-making rather than automatic screening in that age range. The reasoning is straightforward. The colon cancers most likely to be newly discovered in an asymptomatic person in their late 70s or 80s tend to be slower growing, and the years of life that early detection would need to buy back to justify the risk of the procedure are often longer than the person's remaining life expectancy. And the procedure does carry real risk. Bowel perforation occurs in roughly 1 in 1,000 to 1 in 500 colonoscopies, depending on the population studied, and that risk rises with age and frailty. Bowel preparation, tapoktrul and neurotisticine type. The process of clearing the colon before the procedure involves large volumes of fluid and can cause significant dehydration and electrolyte imbalances in older adults, occasionally serious enough to require hospitalization on its own, entirely separate from the procedure itself. None of this applies if you have symptoms, rectal bleeding, unexplained weight loss, a significant change in bowel habits, iron deficiency anemia T, or if you have a personal or strong family history of colorectal cancer or polyps. Those situations change the calculation substantially, and screening or diagnostic workup is generally appropriate regardless of age. For average risk people with a history of clean prior colonoscopies who are simply due by calendar rather than by symptom, it's worth explicitly asking your doctor whether a non-invasive option, a stool-based test like a fecal immunochemical test, FIT, or a multi-target stool, DNA test, might be appropriate as an alternative, and what the plan would be if that test came back abnormal. 2. Aggressive prostate and breast cancer screening. In low-risk, asymptomatic patients. This is the area where the concept of overdiagnosis is best documented, and it deserves careful, non-alarmist explanation. Modern imaging and lab testing are extraordinarily sensitive. They can detect cancers that are, in a real biological sense, indolent, tumours that grow so slowly, or not at all, that a person would very likely die of something else, entirely before that cancer ever caused a symptom. Autopsy studies going back decades have repeatedly found that a meaningful percentage of older men who died of unrelated causes were found, after death, to have had undiagnosed prostate cancer that never caused them any problem while they were alive. Similarly, research published in outlets including the New England Journal of Medicine has estimated that a substantial share of cancers detected through mammography represent overdiagnosis, tumours that, left unfound, would never have progressed to cause harm. The clinical problem is that once a report says malignancy, the healthcare system is generally structured to act, not to simply note it and wait. That's often appropriate. Many cancers absolutely do need treatment. But for low-grade, localized findings in an older, average-risk, asymptomatic patient, treatment can sometimes carry a heavier burden. Surgical complications, radiation side effects, incontinence, sexual dysfunction, prolonged fatigue, than the cancer itself would ever have imposed. This is precisely why active surveillance has become a mainstream, guideline-endorsed option for many low-grade prostate cancers rather than immediate treatment. It is not doing nothing. It involves regular monitoring, repeat testing, and a plan to intervene if the cancer shows signs of becoming more aggressive. For many men, it's now considered the appropriate first choice, rather than a fallback. This does not mean screening is wrong for you. Family history, genetic risk factors, such as BRCA mutations for breast cancer, and any new symptoms are all legitimate reasons to screen and to treat aggressively regardless of age. The point is narrower. If you are average risk and asymptomatic, it's worth asking before you screen what would actually happen if something were found, and whether that treatment would meaningfully change your outlook given your overall health. 3. Cardiac stress testing without symptoms. This one tends to surprise people because it sounds so sensible on the surface. Let's just check your heart. But the evidence here is more counterintuitive than most people expect. In people with no cardiac symptoms, no chest pain, no exertional shortness of breath, no unexplained fatigue with activity, routine stress testing has a meaningfully high false positive rate, particularly in populations where some degree of coronary artery narrowing is extremely common simply as a function of aging. An abnormal result doesn't stay abnormal in isolation. It typically leads to cardiac catheterization, an invasive procedure that threads a catheter through the blood vessels into the heart to directly visualize the coronary arteries. Catheterization carries genuine risks: bleeding, vessel damage, arrhythmia, and, rarely, but not never, it can itself trigger a heart attack or stroke. And here's the part that surprises most people. Several major clinical trials, most notably the ischemia trial, published in 2020, found that in patients with stable coronary artery disease, meaning no acute symptoms, no unstable angina, adding stenting or bypass to optimal medical therapy did not reduce the rate of heart attacks or death compared to medication and lifestyle management alone. The invasive approach didn't outperform the conservative one, but it carried its own procedural risk, plus a lifetime of antiplatelet or anticoagulant medication, which comes with its own bleeding risk. To be clear, this does not apply to people with symptoms. Chest pain, unexplained shortness of breath with exertion, dizziness during activity, or a concerning EKG finding are all legitimate reasons for cardiac workup at any age, and delaying evaluation in the presence of symptoms can be dangerous. This section is specifically about routine, symptom-free stress testing. If you're in the asymptomatic category, the higher yield conversation with your doctor is often about the modifiable risk factors that reliably reduce cardiovascular risk, regardless of what a stress test shows. Blood pressure control, cholesterol management, blood sugar control, physical activity, and sleep quality. 4. Bone density screening and automatic long-term medication. Osteoporosis is a real and serious concern in older adults. Fractures, particularly hip fractures, are strongly associated with loss of independence and increased mortality in the following year. Nothing here questions that. What's worth examining more carefully is the pathway that sometimes follows a bone density DEXA scan. A DEXA scan showing low bone density often leads directly to a prescription for a bisphosphonate. Medications like alendronate or risdronate DAS, often intended to be taken for years. These medications are effective and appropriate for many patients, especially those who've already had a fragility fracture or who have very low bone density, a T-score in the osteoporotic range. But long-term bisphosphonate use has been associated with two rare but serious complications: atypical femoral fractures, unusual stress fractures in the thigh bone that can occur with minimal or no trauma, and osteonecrosis of the jaw, a painful and difficult to treat form of jawbone deterioration. Both are uncommon, but the risk rises with duration of use, which is part of why current guidelines generally recommend periodic reassessment of whether continued treatment is still warranted, rather than indefinite, unreviewed use. At the same time, the research on fall prevention is remarkably strong and often underemphasized. Structured balance training. Tai Chi in particular has been studied extensively and shown to meaningfully reduce fall risk. Combined with home safety modifications, vision checks, medication reviews, since some common medications increase dizziness or fall risk, and adequate protein and vitamin D intake together reduce fracture risk in ways that don't carry pharmaceutical side effects. The reasonable position here isn't avoid bone medication. It's that a DEXA result showing low bone density in an otherwise active person with no fracture history is worth a real conversation about the actual risk reduction the medication offers, the risks of continuing it long term, and whether a structured fall prevention approach might be a stronger first step, alongside medication or instead of it, depending on your specific numbers and history. 5. Asymptomatic carotid artery ultrasound screening. This is a less commonly discussed screening, but the evidence around it is fairly clear-cut. A carotid ultrasound examines the arteries in the neck that supply blood to the brain, looking for narrowing that could increase stroke risk. The US Preventive Services Task Force explicitly recommends against routine, carotid artery screening. In adults with no symptoms, no history of transient ischemic attack, TIA, sometimes called a mini-stroke, no episodes of sudden vision loss, no prior stroke. The reasoning is that carotid narrowing is common in older adults and is frequently stable for years without ever causing a problem, while the surgical treatment for a significant blockage, carotid endarterectomy, carries a measurable risk generally cited in the range of 2 to 3% of causing a stroke during or shortly after the procedure. In an asymptomatic person, the surgery's risk can outweigh the risk the untreated narrowing itself posed. This is precisely the kind of situation the cascade effect describes. A narrowing that was quietly present and stable gets found through screening, gets treated because that's what medicine is structured to do, with abnormal findings, and the treatment introduces a risk that wasn't there before. Symptoms change this completely. Sudden facial drooping, arm or leg weakness, slurred speech, sudden severe headache, or a brief episode of vision loss or confusion that resolved on its own all warrant urgent evaluation, regardless of age, and should never be dismissed or delayed. The recommendation against routine screening applies specifically to people with none of these symptoms. For that asymptomatic group, the more productive investment tends to be in the well-established modifiable stroke risk factors. Blood pressure control, the single largest driver of stroke risk, blood sugar management, smoking cessation, treatment of atrial fibrillation if present, and regular physical activity. A framework for your next appointment. 5 questions worth asking. None of this is meant to make you distrust your doctor or refuse recommended care. It's meant to help you participate in the decision as an informed partner rather than a passive recipient. When a screening test is recommended, especially if you're over 70, feeling well, and this is a routine recommendation rather than one driven by symptoms, these 5 questions tend to open up a much more useful conversation. 1. What is the false positive rate of this test in someone my age? This helps you understand how often the test flags something that turns out not to be a real problem, and how likely you are to be pulled into unnecessary follow-up procedures. 2. If this test finds something, what would the realistic treatment options be for someone with my age and health profile? This shifts the conversation from what might we find to what would we actually do about it, which is often the more important question. 3. What is the risk of the follow-up procedure itself, if one is needed? Every invasive procedure carries some risk. It's reasonable to know that number before agreeing to a test that might lead there. 4. What would happen if we monitored this instead of treating it right away? Watchful waiting or active surveillance is a legitimate, evidence-supported option for many conditions in older adults, not a compromise or a lesser choice. 5. What non-invasive or lifestyle-based approach has the strongest evidence for this specific condition? For bone health, cardiovascular risk and stroke prevention in particular, lifestyle interventions often perform comparably to procedural ones, with substantially less risk. A good physician will welcome these questions. They take time and thought to answer well, and a doctor who's willing to sit with them is generally a good sign about the quality of care you're receiving. If a doctor consistently seems irritated by this kind of question, that's useful information too. Not necessarily about the specific test, but about whether that relationship gives you room to be an informed participant in your own care. Frequently asked questions. Does this mean I should stop going for checkups after 70? No. Regular checkups remain valuable at any age, for blood pressure, medication review, vaccination, vision and hearing, and catching new symptoms early. This is specifically about elective, routine screening for asymptomatic conditions in people who are already feeling well, not about primary care in general. What if my doctor disagrees with something in this video? Your doctor knows your actual medical history, current health status, and risk factors. This video does not. If there's a discrepancy, that's exactly what the 5 questions above are designed to surface. A good conversation with your own physician should always take priority over general educational content. Is this the same as rationing care for older people? No, this is about evidence-based, individualized decision-making, the same standard applied at every age. The guidelines referenced here, USPSTF, major clinical trials, apply the same evidence-based reasoning used across all age groups. They simply produce different recommendations for older, average risk, asymptomatic patients because the underlying biology and risk calculus are different. What if I have several of the risk factors mentioned? Family history, symptoms, or other conditions? Then the reasoning in this video likely does not apply to your situation in the same way, and more active screening and follow-up is probably appropriate. Nothing here is meant as a blanket rule. It's meant to prompt a more individualized conversation. Where can I read the actual guidelines myself? The US Preventive Services Task Force publishes its full recommendations and the evidence behind them at uspreventiveservicestaskforce.org, searchable by topic. It's a genuinely useful resource to bring into a conversation with your doctor. Overdiagnosis, detecting a condition that would never have caused symptoms or shortened a person's life if it had never been found. Overtreatment, treating a condition found through overdiagnosis, exposing the person to treatment risks without a corresponding benefit. Asymptomatic, having no symptoms of the condition in question, the opposite of symptomatic. Average risk, a patient with no personal or strong family history of the condition being screened for, and no known genetic risk factors. Watchful waiting/active surveillance. Structured, ongoing monitoring of a known condition instead of immediate treatment, with a plan to intervene if the condition changes or worsens. USPSTF, US Preventive Services Task Force. An independent volunteer panel of medical experts that reviews the evidence on preventive care and issues national screening guidelines used by most US physicians and insurers. Cascade effect, a chain reaction in which one test result triggers a sequence of further tests or procedures, each individually reasonable, that together carry more cumulative risk than the original problem. False positive, a test result that indicates a problem is present when it actually is not. Physiological reserve, the body's capacity to withstand and recover from physical stress such as surgery, illness, or invasive procedures. This generally, though not universally, declines with age. There's an important distinction between medicine that finds things and medicine that helps a person live well, and after 70, that distinction matters more than it did at 40 or 50. The goal of healthcare in later life isn't to generate the maximum number of findings, it's to protect the things that actually make life good. Independence, energy, mobility, time with the people and activities you care about. This doesn't mean skipping screening, dismissing your doctor's recommendations, or assuming every test is unnecessary. Plenty of screening remains genuinely valuable well past 70, particularly when there are symptoms, strong family history, or specific risk factors involved. What it means is that the decision deserves the same weight as any other major health choice. A real conversation about your specific situation, not a default checkbox on an annual visit checklist. You're entitled to understand what a test is looking for, what would happen if it found something, and whether the resulting treatment would genuinely improve your life rather than simply document a problem. That's not being a difficult patient. That's what informed medical decision-making is supposed to look like at any age. If something in this video changed how you think about an upcoming appointment, or if you've had an experience with a screening test that took you somewhere you didn't expect, that's worth discussing with your own doctor. It may be worth sharing with others who are facing the same decisions. What to do next? If this was useful, here's a concrete way to act on it rather than just remembering it. Pick one upcoming test or recommendation, something already on your calendar or something your doctor has mentioned, and go through the 5 questions with it before you say yes or no to anything. If you found this helpful, share it with someone it applies to. The person most likely to benefit from this isn't necessarily you. It might be a parent, a spouse, or a friend who's about to walk into an appointment with a routine recommendation they haven't thought to question yet. Passing along one useful framework is worth more than passing along general health anxiety. If you want more content like this, subscribing's a reasonable way to see future videos in this series, but only if the content itself has been useful to you, not because the subscribe count needs padding. Judge it on whether it changed how you'll handle your next appointment. And if you take one thing away from all of this, let it be the 5 questions, not the 5 checkups. The specific tests in this video may become outdated as guidelines evolve. The habit of asking what a test is for, what happens if it finds something, and what it would actually cost you to find out. That habit stays useful for the rest of your life.